You're all welcome to this session. This session will be for households from academics. I have a number of guests who will be speaking in this session. We have Ahmed, myself, Isaiah Agoria, and we have Lan Lima, who will be the guest for this session. There are 5 topics that you will want to be to there will be using platform. We have a support chat system. We have a support chat system as well, where you can access the chat functions on how you move around the platform. There will be a question and answer session as well. And then within this session, we will have live answer session, which you will find at the platform once you log in. To be able to view the presentations clearly, you can there's a full screen mode that you can switch to. Until the 31st of March next year, so and capabilities will be for you to adjust your Zoom duration of 7% and be full screen. This session will be available in English and then French. So for the first topic, we can upload the effects on the presentation. Here's some evidence from the in North Bangladesh, represented by Mohammed. He's the fellow with the University of Health in Bangladesh. He's an experienced researcher with multiplication of educational human expertise in economics, and right now, experience has prepared some professional experience in increasing the program challenges. So we will play its recording, and then you can have there'll be a session for us to have questions and answers.
Islam. I'm connecting you from Bangladesh. I'm a researcher currently working at Bragg James P. Brown School of Public Health. Today, I'm going to present you findings from a research that we did last year in 2019. The title of my presentation is Health Loan and its Effects on Healthcare Utilization and Out-of-Pocket Expenditure. Of course, this is a joint work with Dr. Ratanu Rabbani, Professor Manuela D. Allegri, and Professor Malavika Sharkar. So without further ado, let's dig into the presentation. What was the motivation behind this research? We all know that health shock exposes many households to financial catastrophes, especially in low and middle income countries. Poor households are especially vulnerable to this situation because they rely mostly on self-insurance mechanisms and plain old social capital to cope with the health shock, to cope with the high out-of-pocket payments relating to the health shock. On the other hand, the insurance coverage is very low due to the scarcity of appropriate risk pooling mechanism. So based on prior researches, we know that microcredit in this particular context where health insurance coverage or any kind of insurance coverage is very low, microcredit plays a role, a sort of a partial role of insurance for the risk-averse households. So understanding the gravity of this problem, in 2013, Bragg, which is the largest non-governmental organization in Bangladesh, they started providing a small health loan to their existing microcredit clients. They call it medical treatment loan. Problem is to avoid the loan misuse, applicants need to go through a very complex verification process, which often makes their lives difficult and the disbursement procedure lengthy. So the demand for this MTL is very low. So what we did, we revised this application process and the payback modalities, and we call this new product MTL Plus. So the standard product is MTL, and the new product that we designed or remodeled is we are calling it MTL Plus. So what are the difference between MTL and MTL Plus? Let's look at that. So the eligibility criteria, we have revised it. For the standard loan, only existing current borrowers can apply for the loan. But for the new product, all the members, whether they're current borrower or not, they can apply for the loan. We simplified the verification process. For the standard loan, they need to go to an empaneled, BRAC empaneled doctor, and the doctor will verify the need and will provide them with a estimated treatment cost, and they have to apply for the loan with the document, with the verification document from the physician. But for the new product, they don't need that. They just come with any prescription from a legitimate doctor, and we will verify that and we will provide the loan. For the new loan, they have more payback options, but for the standard loan, they just have to pay it within 12 months. And for the new loan, they have no pre-specified loan ceiling. But for the standard loan, it is just 50,000 Bangladeshi taka. We wanted to look at 3 different research questions. First of all, we hypothesized that the newly designed product, MTL Plus, the transaction cost will be very low. Reducing this transaction cost increases the loan uptake or not. We wanted to see the possible effects of this loan use on formal healthcare utilization and out-of-pocket expenditure. To do that, we applied a randomized controlled trial to offer the loan products to their potential clients. There are 56 branches in Rangpur. We selected 24 equivalent branches, equivalent in terms of capacity in handling clients. And we randomly selected 12 branches to offer the new product, which is MTL Plus. And the other 12 branches, they continued offering MTL. Now here we can see the loan uptake rates for both MTL and MTL Plus. The blue line represents the loan uptake rates for MTL, the standard MTL, and the orange line represents the same for MTL Plus. We plotted loan uptake rates for a period of 10 months here, from January to October, but we launched MTL Plus in May. So from May onwards, you can actually see MTL Plus has generated higher demand in this May to October period. If we concentrate on specific loan characteristics, you will see that MTL Plus has generated sort of a double demand, both in terms of number of loan disbursed and the amount of loan that has been disbursed in this May to October period. To compare the healthcare utilization and out-of-pocket expenditure of the borrowers, we surveyed all the health loan borrowers and also equivalent number of eligible non-borrowers. Why they're eligible non-borrowers? Because they have also suffered from some sort of illnesses, but they didn't took the loan. So they are eligible non-borrowers. And we interviewed them and we matched their illness incidence with the MTL Finance illness incidence. For that, we applied a propensity score matching technique, and we matched the borrower's data with the eligible non-borrowers data based on 3 types of variables. First of all, the type of illness, the duration of the illness, and the characteristics of the members who took the loan. Here we are simply comparing the formal healthcare utilization between the case and control households for both MTL and MTL Plus. Both case households, which are the loan borrowing households, are showing higher tendencies of seeking formal health care in comparison to their eligible non-borrowers. But for MTL Plus borrowing households, this formal health care seeking is way higher compared to control households and standard loan borrowing households. If we look at this data in a multivariate environment, we can see after controlling for the confounding factors, if we try to estimate the average marginal effect of this loan borrowing on formal healthcare access, we found that if you MTL, the standard MTL taking households are 22% more likely to visit a formal healthcare provider in comparison to their eligible non-borrowers. Whereas MTL plus households are 36% more likely to visit a formal healthcare provider in comparison to their eligible non-borrowers. So borrowing households are spending much higher in comparison to their eligible non-borrowers. So MTL households, they are spending on an average 15,000 Bangladeshi taka for their health incidents, whereas MTL plus households are spending around 19,000 Bangladeshi taka. We also estimated the association between loan uptake and out-of-pocket health expenditure, and we found that the relationship is positive. And the standard MTL households, in comparison to their eligible non-borrowers, are spending 96% higher in comparison to their eligible non-borrowers. Whereas MTL plus households, for any outpatient visits, they're spending 131% higher in comparison to their respective non-borrowers. That brings us to the conclusion. What are the takeaway messages from this research? So we found that immediate access to finances relaxes the liquidity constraints. Access to credit increases the formal healthcare utilization. It increases households' health expenditures, at least in the initial stage. And relaxation from this liquidity constraints provides the household with an option to smooth their income. So health loan can be taken as a possible short-term alternative if the health insurance is not there. For additional information, you can reach me at this email address. Thank you.
Apologies, we had some technical difficulties, so I will now be taking over the moderation from Isaiah. Thank you, Isaiah. For our next presentation, we have Edouard, who is from Burundi. And I just wanted to add, for any Francophone viewers, there is French interpretation for this entire session available. En français, il y a une traduction en français est disponible pour cette session. And we'll continue on to the next presentation.
Excuse me, sorry, can I ask something?
Yes.
How can we introduce the translation, or where can we find the?
So hopefully the host can answer that question. I believe it's through the platform, but I'm not sure how that is accessible. My apologies. I've just been assigned as the moderator at the very last minute here.
Okay, because actually I'm the only one speaking English here, and we're all following everything, and like my colleagues can't really understand what's going on. So.
Yes.
For the interpretation, you need to go to the platform. Under the session information, you can select the language.
Wait, we have to, do we have to tu veux? Ils disent qu'il y a une traduction qui est disponible quelque part, monsieur. Okay. So we have to, do we have to
La présentation concerne l'analyse comparative des coûts des soins chez les mutualistes et les utilisateurs de la carte d'assistance médicale au Burundi. Une analyse qui a concerné 18 mois, de janvier 2018 à juin 2019. C'est-à-dire au moment où le Burundi s'achemine vers la couverture de santé universelle, nous assistons à plusieurs mécanismes d'accès aux soins et certains se juxtaposent sur les mêmes cibles, comme les mutuelles communautaires de santé et justement la carte d'assistance médicale. C'est-à-dire qu'un choix devrait être fait entre les deux mécanismes, et une proposition comparée des coûts nous permet de proposer un mécanisme efficace, efficient, durable pour une couverture de santé universelle solide. L'objectif général est de contribuer au choix des meilleurs mécanismes de financement de la santé pour une couverture de santé universelle au Burundi. L'hypothèse étant que les mutuelles communautaires de santé constituent un des mécanismes plus efficaces, efficients, durables pour une couverture de santé universelle. L'analyse couvre une période de 18 mois, comme je l'avais dit, et les chiffres sont exhaustifs sur la période et ont été collectés dans les 8 mutuelles de santé appuyées l'ONG MEMISA Belgique au Burundi et chez les utilisateurs de la carte d'assistance médicale assistée par cette ONG. Les chiffres sont exhaustifs pour la période et pour les utilisateurs de la carte d'assistance médicale et pour les mutualistes. Les principaux résultats, c'était que le coût total moyen d'un épisode de maladie chez un utilisateur de la carte d'assistance médicale était de 3 439 francs burundais et il est de 4 232 francs burundais chez les mutualistes. Les petits risques ont un coût moyen d'un épisode de maladie de 2 959 francs burundais pour les utilisateurs de la carte d'assistance médicale et de 3 098 francs burundais pour les mutualistes. Pour les gros risques, la tendance s'inverse. Le coût moyen d'un épisode de maladie chez un utilisateur de la carte d'assistance médicale est de 49 944 francs burundais et il est de 25 048 francs burundais chez le mutualiste. Les dettes de la carte d'assistance médicale aux formations sanitaires est plus élevée et énorme par rapport aux mutuelles de santé qui n'observent aucune dette envers les formations sanitaires. En conclusion, même si le coût moyen d'un épisode de maladie est plus élevé chez les mutualistes que chez les utilisateurs de la carte d'assistance médicale, il est à noter que les forfaits de la carte d'assistance médicale ne couvrent pas tous les coûts réels et que la carte d'assistance médicale est subventionnée par l'État qui arrive difficilement à rembourser les formations sanitaires. Les mutuelles communautaires de santé couvrent les coûts réels et remboursent à temps, ce qui stabilise la trésorerie des formations sanitaires et leur fonctionnement. Pour une couverture sanitaire universelle, les mutuelles communautaires de santé constituent donc un meilleur mécanisme d'assurance maladie pour mieux financer de manière efficace, efficiente et durable le système de santé et de soins au Burundi. Je vous remercie.
Merci, Edouard. We are now moving on to our next presentation. We have Isaiah now presenting on the effect of health expenditure questions on measurement of out-of-pocket expenditures from Northern Ghana.
Good day. My name is Isaiah Goria. I'm with the University of Health and Allied Sciences, and I'm here presenting a topic on the effect of the specificity of health expenditure questions in the measurement of out-of-pocket health expenditure. This was a study that was conducted in Ghana, in the northern part of Ghana, and it's an in-depth project that sought to look at developing alternative methods for measuring household out-of-pocket payment in low and middle income countries. By way of background, healthcare costs is increasing from 7 trillion in 2011 to about 7.3 trillion by 2015, representing 10% of global GDP. The health economy, as we know it, grew faster than the global economy between 2000 and 2015. It grew at a rate of 4%, an annual rate of 4%, compared to an annual rate of 2% in economic growth. However, global health spending remains very unequal. 8% of the world's population live in low and middle income countries, but these countries account for only 20% of global health spending. Household out-of-pocket payments are a part of the global mix of financing mix in almost every country, and they account globally for about 33% of healthcare financing. This out-of-pocket health payment is highest in lower middle income countries, about 41% of the share of total spending, compared to 21% in higher income countries. Therefore, out-of-pocket payment as a financing represents a huge major financial burden for households that are spending out of their pockets for healthcare. Okay, it is estimated that about 800 million people globally incurred catastrophic payment as a result of out-of-pocket payments in 2010, and by 2015 the number had grown to 930 million. This gives us a very worrying situation where we need to be able to track poverty and track the expenditures on healthcare if the interest is to eradicate poverty and also to see how we can achieve or attain universal health coverage. The measurement of out-of-pocket payment is very crucial in the SDG era, and therefore contributes significantly to SDG 1 and that of 3. There are generally two main sources of data for measuring out-of-pocket payments. The first is routine administrative data, which is common in most high-income countries because they have structures built to collect such data. In low and middle-income countries where the structures are non-existent, they rely on household surveys to collect such data to measure out-of-pocket payments. These surveys are bedeviled with a lot of limitations that make it impossible or near impossible to be able to accurately measure out-of-pocket payment and also compare them over time and then payments in these countries. The first being the general household survey, and the second being the health survey. We will focus on the general household survey because this is the survey that is mostly used by different countries. The limitation in these questions in this survey is that the questions are not standardized, and the health expenditure questions are comprehensive but not specific. And for that matter, comparison across different countries is a difficulty. And that's why this study was set up, to see how we can test specifically how different number of questions affect the measurement of out-of-pocket payments, and then therefore at the end giving recommendations on how we can proceed with this. The study was conducted in the northern part of Ghana, where there's a demographic surveillance system monitoring over 160,000 individuals living in 33 households. Basically, we focused on two spending categories, that is inpatient care and medicine, because these were the main drivers of out-of-pocket spending in the study area. We developed 3 different versions of questionnaires where we had inpatient 2 questions on inpatient care, but 11 questions overall in health spending. The second version with 14 questions and 44 overall. We have 14 questions on inpatient and 56 overall. We compared each and every one category of these surveys to health provider data, which we used as our gold standard. We estimated the bias, that is the difference between the expenditures reported by the household and that of the gold standard. And then we looked at the ratio of the bias between the version 1, which is a minimum number of questions, to version 2, which has 14 and 44, and version 3, which has 14 and 56. We did similarly with medicines, looking at 2 questions compared to 9 questions on medicines, and then 16 questions on medicines. In each of these levels, what we did was to systematically decompose each level to have more detailed questions and increasing the number of questions. We applied the Bland-Admans method comparison, where we had 2 plots. We had the Bland-Adman plots, where we quantify the mean bias and the overall variability. For the version 1, with its provided data, we found that the bias was about 3.2. When the number of questions increased to 14, the bias increased to 6.2. And then when we have the number of questions increasing to 14, but total overall questions increasing to 56, the bias increased to 9.2. When we estimate the ratio between version 1 and version 2, we had about 1.6. And then when we compare the variability there, it was about 1.35. We do the same for version 1 and version 3, and we realized that there was variability between version 1 and version 3, version 1 and version 2, but there was no difference in the bias. Bias was rather found between version 2 and version 3, where the number of questions increased from 2 to 14, and then from 11 to 66. Similarly, we did the same for the medicines, and we found that there was only difference in the bias between version 1 and version 3, where we have two items comparing to 16 items, but there was no difference between 2 items and 9 items. This study has given us evidence to suggest caution in interpreting out-of-pocket health expenditure from different survey instruments. This is information that is already available, but this study proves and has given us enough evidence to also contribute to such knowledge. What we found here is that systematically decomposing health expenditure items into more specific and finer subclasses lead to lower averages for most of the spending categories, especially medicines and inpatient care. And then it also decreases the level of agreement with provided data when you systematically decompose the health expenditure questions. Thank you so much. I wish to acknowledge the following people for contributing to this study, especially Swiss Tropical and Public Health Institute and the In-Depth Network. Thank you.
Thank you, Isaiah. Very interesting presentation on a survey experiment. Now we're moving on to Lan's presentation, which sounds like it's very topical for researchers in the times of COVID, comparing face-to-face data collection and mobile phone data collection.
Thank you for your introductions. I'm very glad to present my study, the result of my study, with the title, A Comparison of Face-to-Face and Mobile Phone Data Collection Method for Estimating Out-of-Pocket Payments. First, so what is out-of-pocket expenditures? Out-of-pocket payments are direct payments that patients and customers pay to healthcare provider when receiving health services. Those payments exclude any prepayment or reimbursement by health insurance. And why is it important for measuring out-of-pocket expenditure accurately? The first reason is out-of-pocket expenditure is a dominant health financing source and account for 40 to 50% of total health expenditures in low and middle income countries. Out-of-pockets represent the major financial burden of households. In 2015, globally, more than 900 million of people suffer from catastrophic payment and impoverishment due to high ups. And out-of-pocket expenditures is one of the important indicators for policymakers. Those payments are important elements to estimate catastrophic payment and impoverishment, which are very important indicators for tracking the financial protection in health of households and for policymakers to improve and have some program and intervention to improve the health system. So in this study, I would like to, so in the next slide, I would like to say something about the rationale of the study. So in low and middle income countries, most of the main source of information for measuring out-of-pocket expenditure are household survey. However, those household survey are mostly face-to-face and multi-purpose survey, which are expensive to be conducted and every year. It's also time-consuming to get the data from those survey available, and it is not doable during some special situations, such as for the face-to-face survey, such as a national disaster, or this year during the COVID-19 pandemic. So in this study, we would like to investigate an alternative mode of data collections, which is mobile phone survey. To answer the questions, can the mobile phone survey be an alternative tool for collecting out-of-pocket expenditures? And we came up with the study objectives, which is to compare the out-of-pocket estimate by face-to-face and mobile phone survey. The study was conducted in the Ba Vy district in the north of Vietnam. The Ba Vy district has more than 300 clusters in 3 demographic characteristics. In 2018, there were 31 communes with an estimated population over 280,000 people. There is one public district hospital, 3 polyclinics, 31 commune health centers, and more than 500 private providers and drugstores. This is a cross-sectional study using data from 2 sources, household survey and hospital records to measure UPS. The study instruments were adapted from Vietnam Household Living Standard Survey 2014, classification of consumption according to purpose 2018. We designed 2 collection methods, which are face-to-face and mobile phone, with the same set of questions for household health expenditures. And the household were sampled using both community and provider sampling and were randomly assigned to 2 data collection methods. In this study, we conduct 2 analyses. The first analysis is Unmatched Analysis, in which we compare the mean annual UPS for all spending categories and compare the estimated ratio between the 2 methods. And the second analysis is a matched analysis. That is, we link the household reported inpatient transactions with their corresponding transaction in the hospital record. And then we assess the agreement between the inpatient UPS reported by household and hospital in terms of bias and variability. When conducting this analysis, we realized that the hospital data are not a perfect gold standard because the respondent might reported the expense incurred in the different provider than the one we selected for validations. However, we're still thinking that is a worth to doing this analysis. And the first result is a ratio of mean annual UPS reported by household. And we can find the consistent patterns that the mobile phone tend to report higher UPS than face-to-face. We can see here most of the ratios in both community and sampling category and across different spending categories are greater than 1. And only in the case of total UPS of the community sampling, we found a significant effect. The second result from the match analysis is an agreement between household provider UPS by collection method. We conduct the analysis for all samples. First, we estimate the mean ratio of each method and the limit of agreement, which is a range that 95% of the ratio lie. And we found that the mobile phone survey has a slightly higher ratio and the larger limit of agreement compared to the face-to-face survey. However, we found there is no difference in the ratio. There is no evidence of difference in the ratio between household and provider between the 2 methods. And then we conduct the same analysis for the 2 categories. So we think that we expect a larger variability for the household with the very low provider UPS. So we divided the sample into the 2 groups of household with the provider UPS less than or equal to $8.8 and otherwise. We conducted the same analysis and we found that for the household with the provider UPS in very low provider UPS, we found that the mobile phone we have a larger limit of agreement, which implies that they have a larger variability. But we found no evidence for this group also. And in the household with the provider UPS greater than $8.8, we found a smaller increase of variability in the ratios for the mobile phone. However, in general, with all of the analysis for the all sample and for the 2 categories, we found there is no evidence of difference in the ratio of household and provider between mobile phone and face-to-face survey. And there was a small increase in variability in the ratio for mobile phone for household with provider UPS greater than $8.8. So taken together, the result from the unmatched analysis and the matched analysis, we conclude that the mobile phone interview can be an alternative method for collecting data for measuring ups, especially inpatient episodes. Yes, so thank you for your attention.
Thank you. Now we're moving on to my presentation. And as some of you may have noticed, I have a tendency to speak quickly, which is probably even worse in my recording. So I apologize in advance and will be happy to answer any clarification questions during the Q&A. In this presentation, I consider how to measure the equity of interventions where public funding is used to subsidize the private sector. This work is relevant to this session because my central argument is that standard approaches are insufficient for these interventions because they do not factor in out-of-pocket payments. I focus on an intervention that subsidized malaria treatments. ACTs are the recommended first-line treatment for malaria. Use of ACTs has been increasing over time. Despite ACTs being officially free in the public sector, many people seek treatment in the private sector where ACTs are more expensive than other treatments, and therefore many patients choose other non-recommended treatments over ACTs. This is especially a concern because in many high-burden countries, more patients seek care in the private sector over the public sector. And I should note that when I say private sector for the purpose of this presentation, I'm referring to the private for-profit sector. AMFM was implemented in 2010 to 2012 by the Global Fund at a national scale in 7 countries. The intervention had 3 components. First, there are negotiations with manufacturers to get them to lower their prices. Second, a co-payment or subsidy paid by the Global Fund to manufacturers for each unit ordered through the intervention. And this was a substantial subsidy. It covered 95% of the manufacturer's selling price. For example, if the manufacturer sold a treatment for $1, the Global Fund would pay the manufacturer 95 cents, and the wholesaler would pay only 5 cents. The idea behind the intervention was that the subsidy would be applied at the top of the distribution chain and then flow through the normal private sector distribution channels. And finally, there are interventions to support effective scale-up, and this included things like mass communication campaigns. AMFM was extremely controversial. For example, AMFM produced a report shown here that emphasized many of the criticisms of the intervention. And the prime concern was that AMFM would only benefit the rich because others could not afford to buy the subsidized medicines. So in light of these concerns, we assessed the equity of AMFM in 2 ways. First, we followed standard practice and looked at disparities in the use of AMFM subsidized drugs. We compared the use of AMFM with 2 alternative delivery mechanisms: subsidized delivery of antimalarials through the for-profit sector, and unsubsidized delivery of, we compared AMFM with subsidized delivery of quacks through the public sector, and also with unsubsidized delivery of antimalarials through the for-profit sector. The standard approach is useful as it helps us to understand who uses which distribution mechanism. It helps us to answer the key question of whether the poor participated in the intervention. The problem is that it doesn't give us the full picture. Retail prices may vary across groups, for example, due to the presence of local monopolies or high costs of transporting products to rural areas. This leads to our second approach, which is a novel extension of benefit incidence analysis methods. BIA methods assign a monetary value to health services. How this is done depends on the sector that delivers the services. What we found was that existing BIA methods are not fully appropriate for private sector subsidy interventions like AMFM due to their intersectoral nature. So we developed a price gap approach to value benefits of an AMFM subsidized drug. And so the price gap is the difference between a counterfactual price and the price that the patient actually paid. And this is how we factor in variations in out-of-pocket expenditures into the equity analysis. And we compare the equity of AMFM using the price gap approach to our results from the utilization-based approach. I should note that it wasn't feasible for us to do this part of the analysis for Nigeria because there wasn't sufficient data. So our analysis uses nationally representative household surveys of malaria treatment seeking behavior in Nigeria and Uganda collected through the ACT Watch project. These data were collected in early to mid 2012, which was after about a year of implementation of AMFM in the 2 study countries. And so we measure equity with the concentration index or concentration curve and measure socioeconomic position with a wealth index. So to put the results of the equity analysis in context, we first looked at the proportion of febrile children that were treated with an anti-malarial obtained through the 3 delivery mechanisms. In Nigeria, the unsubsidized for-profit sector, shown in red, was the most popular source of anti-malarials, and their use was similar across quintiles. We also see in Nigeria that use of subsidized quacks, whether they're from a for-profit outlet, shown in green, or the public sector, shown in blue, was much lower than the unsubsidized for-profit sector. But we also found that use of these delivery mechanisms was higher in the richest quintile compared to the poorest. In Uganda, the subsidized private sector, or AMFM, was the largest source of treatment. Use of this mechanism was highest among the poorest quintile compared to the least poor, and we saw similar patterns with the subsidized public sector, with children from the richest quintile being less likely to receive a subsidized quack from the public sector compared to children from the poorest quintile. This figure illustrates our results for the equity analysis of our utilization-based approach. The dotted lines are the concentration curves for 3 delivery mechanisms. So the 45-degree line is called the line of equality. If a curve lies along that line, that means there's equal use of the distribution mechanism. The unsubsidized private sector, which is shown in red, runs along the line of equality in both countries. The other thing to know about interpreting a concentration curve is that the more the curve bows away from the line of equality, the more unequal the distribution. And if the curves lie below the 45-degree line, that implies that the distribution is pro-rich. And this is what we find in Nigeria for both the subsidized public sector and the subsidized private sector, or AMFM. In contrast, if the concentration curves are above the line of equality, that means the distribution favors the poor. And this is what we find in Uganda. In other words, the distribution of subsidized quacks from either public or private sources was pro-poor. If we move on to the results from our BIA, recall that our bright price gap method allows us to see whether there are disparities in the prices paid by households for AMFM subsidized drugs. The leftmost column shows the concentration index for our utilization-based valuation. The concentration index is just a summary measure of the concentration curve. So this is really just showing our results from the previous side for AMFM in a different format. And the negative coefficient here indicates the pro-poor distribution that we showed previously. And now if we look at the point estimates from the BIA, we see that they've decreased compared to the utilization valuation. This indicates when we incorporate out-of-pocket payments paid by providers, the pro-poor distribution becomes greater. That means that concerns that patients from poor households may pay more for AMFM subsidized drugs were unwarranted. In other words, poor households were paying less to obtain the subsidized drugs compared to richer households. So I'd like to highlight 2 policy implications of our results. So first is interventions delivered through the private sector do not necessarily exclude the poor. We found that poor households were also not necessarily facing higher prices in the private sector. And secondly, subsidies in the public and for-profit sector were not sufficient to provide universal access to ACTs. Households from all quintiles, including the poor, continued to purchase unsubsidized anti-malarials from for-profit outlets. And this may have happened for a number of reasons. So availability of subsidized quacks in public and private outlets may have been low in some areas. We found evidence of unofficial charges for treatment in the public sector in Nigeria and some results that I didn't show in this presentation. And patients may have preference for non-ACTs. And so there are a number of limitations of this study. One thing I'd like to highlight is that these results may not be generalizable to other settings. Particularly Nigeria and Uganda were weak performers on the price outcomes. And then there are also a number of limitations related to the nature of standard household survey data of malaria treatment-seeking behavior. And so I'd like to end the presentation by thanking the funders of this work and the viewers for tuning in. Thank you all. We'll now move on to the Q&A portion of this session. So just looking at the questions, First, I will ask the question for Eduardo, and I will read it first in English and then translate it to the best that I can in French. And I apologize in advance because my French is a bit rusty. So the question in English was, evidence on community-based health insurance shows that they offer limited protection, are often not financially sustainable, or difficult to pull off at a higher level, and does not allow achieving universal coverage. So are there efforts in Burundi to pull all community insurance together and make them compulsory? Alors, Eduardo, la question pour vous est les preuves sur les assurances communautaires montrant qu'elles offrent une protection limitée ne sont souvent pas financièrement viables, sont difficiles à atteindre à un niveau supérieur et ne permettant pas d'atteindre une couverture universitaire. Est-ce qu'il y a des efforts en Burundi pour rassembler toutes les assurances communautaires et de les rendre obligatoires?
Allô?
Allô?
Hello.
Alors oui, ok. Vous pouvez répéter la question?
Oui, alors la question était vraiment si les différents programmes d'assurance communautaire seront rassemblés dans un programme obligatoire.
Ok, aujourd'hui justement avec cette fragmentation des mécanismes qui sont ici, dont ce que j'ai présenté, on est en train de faire tout ce qu'il faut pour que l'assurance maladie devienne obligatoire au Burundi. Et donc tous ces mécanismes-là pourront être dans un système d'assurance maladie qui peut permettre effectivement d'évoluer. Donc, aujourd'hui, par exemple, au niveau du pays, il y a une étude d'abord de faisabilité de l'assurance maladie obligatoire et l'étude va bientôt commencer. Également, une autre étude qui va en parallèle voir la faisabilité de l'assurance de la couverture de santé universelle. Donc, les deux études-là sont des gros chantiers, évidemment, qui doivent passer par un registre social unique pour qu'on puisse évoluer rapidement vers une assurance maladie obligatoire. Et les jalons qui sont déjà là, c'est que la couverture géographique jusqu'aujourd'hui est plus large, près de 80% du territoire est déjà occupé. Donc, une fois qu'on passe à l'obligation de l'assurance maladie, donc, nous espérons que les choses vont aller vite vers la couverture. Voilà, c'est ça.
So I believe that is being back translated into English, but just in case it is not, I will do my best to translate it into English for the Anglophone attendees. So my understanding is that there are two studies ongoing to address the issue of fragmentation. One of the studies is looking at the effect of having the insurance being obligatory. And the second study is looking at just the feasibility of a universal health coverage system. Currently, there is 80% geographic coverage of the various fragmented health insurance systems. So they think they can move quickly on universal coverage. So I hope that I have that correct. As I said, my French is a bit rusty and I was not prepared to be in this moderating role, but we'll move on to the next question. Okay. So now the one thing that I'm not sure if we added at the start of the session today was our first presenter was not able to join us live. So the question that we have for Muhammad Islam will not be able to be answered live today. So now we're moving on to a question for Isaiah. What do you think drives the difference between more detail and less detailed questionnaires on health expenditure? And a follow-up question is a very similar question on what do you think, or why do you think these differences occur across the question sets? And what would you recommend for future surveys?
Okay, thank you very much. Can you hear me clearly?
Yes, we can hear you.
Okay, so one of, let me say, the main driver of these differences is that most of the population is more illiterate. So, they are not well informed, or they do not know most of the names of medications and even diagnosis that is given to them. So when you get more detailed and get more finer in asking specific questions, people are not able to tell you specifically what they spent the money on. They can tell you that they spent money on malaria, but once you get in detail and start asking about the type of medication that was given, if it's an ACT, and then you get more specific asking about the type of ACT that is given out, they are not able to tell you specifically what they got. So they end up getting errors from that. So I recommend, or from our evidence of our study, we recommend that we should keep it at a certain aggregated level, and that way you are able to get more accurate reporting from the households rather than asking more specific. So the more detailed you get, the less it is that people less likely is it that people will be able to tell you specifically what they spent on.
That's great.
I
Thank
hope
you.
I made it clear. Yeah.
Yeah, I actually have a follow-up question on that because this is something that I'm interested in. Do you think it's related to the salience of expenditures?
Come again?
So that means that sort of expenditures that occur sort of more frequently. So for example, purchasing an anti-malarial versus a larger expenditure that's more rare was perhaps more salient and more memorable to the purchaser, to the patient.
Yeah, so there was I have another paper, another presentation, a poster, which looks at recall, and we try to look at accuracy with recall as well. And then this was basically for looking at it separately for inpatient care and then medicines. I mean, realize that there was a bit of a better agreement in medicines than in outpatient care. And when the recall period was longer, we had 12 months compared to 6 months for inpatient care, and then 2 weeks compared with 4 weeks for medicines. So people are able to remember more frequent things than things that they bought at a longer time. And they're also able to remember expenditures for events that were considered serious and minor events. So someone could just buy a painkiller. I mean, they buy those ones on a daily basis. So they are able to remember how much it cost. But when you begin asking about the same painkiller, how much they bought it maybe 6 months ago, then the memory issue comes in, the recall issue comes in. So we're looking at recall period and also looking at the accuracy of it. And I think that our evidence is very interesting. You should try and check that one out, the poster out, and then you can get in touch for maybe more information on it. But bigger things were remembered more than smaller things, and a shorter recall period was more recommended for asking out-of-pocket payments.
Oh, very interesting. Thank you.
Yeah.
So I think I'm. Yeah. So question here for Lan. So the question is from Darius asking, if I understand correctly, the disagreement between face-to-face and mobile are increasing when OP was high. Would it not create bias? And any idea of what drives the disagreement between those two methods?
Thank you for your questions. So the idea that when we categorize the OOF into the two different category of provider OOFs that are lower than 8.8 US dollar or higher than 8.8 US dollars, because within this study we include the household that incur zero during the survey. And with the zero, when we conducted the analysis using the blank Unmatched method to calculate the ratios, we found that with the very low provider oops, we have a very high variability. So in order to check whether we have the consistent pattern according to the throughout the different oops, so we decided to do the analysis like this. And you're right to say that the mobile phone survey tend to have higher ratio with the higher provider oops. Yes, because the household with the oops, the positive oops, they remember more, and that's the reason why they report the higher for in. And when we look at the I did not show it in the presentation, but when we look at the breakdown for expanding categories, for the mobile phone survey, they tend to report higher oops for outpatient compared to the face-to-face. And I think that's the reason why we have a higher, but not significant bias between the two methods. Yeah.
Thank you so much. We have another question for Isaiah here. And so the question is, could there be a possibility that provider reported spending may not be a gold standard for given households? May some of the medical supplies and lab services needed from outside, so given the unavailability in the facility, are that they're getting care, or maybe under the payer table payments? So while understanding the difference is important and useful, perhaps we need to be careful what we frame as a gold standard.
Yeah, he's absolutely right. This was something that came up in the course of the study. Fortunately, we did the study with Lan, who is also presented there. So this was done in Ghana, both Ghana and Vietnam, and we had the same design and approach. And considering the provider data as a gold standard was something that we had to think through. It was the only thing that we had close to a gold standard that we could actually use. So what we did was to try to spend some time to strengthen data collection at the provider level, to try to remove as much bias and errors as much as possible, and then use that as a gold standard. We acknowledge that it is a big challenge.
Great, thank you.
We know that, we need to have that in mind when interpreting the data.
Great, thank you. So now I've got a question for my presentation. The first one is the concern about subsidizing the private for-profit sector for individual interventions is that they may impact out-of-pocket expenditure by getting patients in the door and then adding unsubsidized services and drugs. Were you able to check if this was a problem in Nigeria or Uganda? So that isn't something that we looked at in this study. It is something that could be done. In general, one of the things that I didn't get into was the missing data problem with out-of-pocket expenditure. So in the surveys, households were either asked to spend the total amount that they spent on the visit or the amount that they spent actually to buy the ACT. So the reason why I had to do the multiple imputation analysis in the benefit incidence analysis was because many patients only reported the cost overall for their visit to a particular provider. So we use that data in order to impute the value of an individual drug. But yes, you're absolutely right that this is a concern. It is something that we could look at, but it was a bit outside of the scope of this analysis. And so the next question regarding my presentation is why such difference between countries? Is it contextual issues, incentive mechanisms, something else? also specific districts in Nigeria or across all. So the surveys that we used were nationally represented surveys of both countries. And in terms of the differences across countries, in the full paper, we spent a lot of time thinking about what might be driving these results because they were so different. One of the things that is potentially driving the Nigeria results for the public sector is we found that households were reporting that they were paying to receive treatment when treatment for children under 5 in the public sector in Nigeria ought to be free. And those informal payments, in contrast, were not reported by households in Uganda. In terms of why the uptake was higher in Nigeria, of AM/FM was higher in Nigeria compared to Uganda, there's many possible contributing factors. Nigeria has a very large domestic manufacturing capacity. There's also, the private for-profit sector includes a wide variety of retailers that are already selling various types of medicines. And then this gets to another question that someone else had, was that it looked like unsubsidized ACTs in the private market is closer to the line of equality in both countries. And I want to add that that's not actually unsubsidized ACTs, that's unsubsidized treatments. And so that includes non-artemisinin therapies, which are in addition to other classes of ACTs, which tend to be less expensive. So at the time that these surveys were conducted, non-artemisinin therapies were the most common treatments obtained in the private for-profit sector. So it was really that the households that didn't use an AM/FM ACT or an ACT from the private sector were instead getting non-artemisinin therapies that were sort of cheaply and widely available before the intervention in both places. And then regarding my recommendations for subsidies for ACTs, I think we know that the private sector remains a challenge. One thing that wasn't addressed in AM/FM was the availability of diagnostics. And I think going forward, how to have subsidized diagnosis and how to scale up subsidized diagnosis and treatment would be a challenge. And I don't think that there's enough evidence yet on how that can be done well. So I think that's really looking at the bundling of subsidized drugs and diagnostics would be the way forward in certain countries. Okay. Okay, so there's a question. Pourquoi, is this from you, Edward? Pourquoi continuer avec les mutuelles quand on sait qu'ils ne permettent pas la CMU, en gros, et n'offrent que peu de protection?
Oui, est-ce que vous pouvez répéter?
So this is just something that came up in the traduction de ma question. Pourquoi continuer avec les mutuelles quand on sait qu'ils ne permettent pas la CMU, en gros, et n'offrent que peu de protection?
Pour le cas du Burundi, nous pensons qu'avec les mutuelles communautaires de santé qui couvrent le milieu rural et le secteur informel, et qui constituent la grande majorité de la population, plutôt les mutuelles de santé permettent de couvrir une grande partie de la population qui aujourd'hui n'est pas totalement couverte. Donc, si on passe à l'obligation et que les gens entrent dans les mutuelles de santé, une grande partie de la population sera plus couverte. Donc, voilà pourquoi nous insistons sur les mutuelles de santé, parce qu'ils vont couvrir la plus grande partie de la population. Aujourd'hui, les autres systèmes d'assurance ne couvrent qu'à peu près entre 6 et 10% de la population. Donc, si les mutuelles de santé pouvaient couvrir le reste de la population, donc vous voyez que la couverture serait plus accélérée par rapport à ce qu'on est aujourd'hui.
Okay, thank you. Merci. So the translation of Edward's answer into English is the mutuals cover rural areas and the informal sector, and other programs only cover 6 to 10% of the population because they exclude rural areas and exclude the informal sector. I hope I got that accurately. I don't seem to have any. C'est ça. Okay, merci. I don't see any further questions in the Q&A. I think we have about another 8 minutes left. So if there are any other questions, we would be pleased to answer them. Yes, I think that I'll give everyone another minute in case there are other questions left, but if not, we can maybe sign off early. I'm not seeing anything added. Great. Well, if there are follow-up questions, please get in touch with the individual presenters. And I'd like to thank all the attendees and all the presenters for joining the presentation. Alors, Edward, nous n'avons pas plus de questions maintenant. Alors, on va terminer la session. Et un grand merci pour vous et à bientôt. Merci.